Good morning, everyone. It gives me great pleasure to welcome you to the first BC Rural Health Research Exchange. My name is Nellie Oakey, and I am one of the co-scientific directors at Rccbc. I am going to turn it over to Tracy, who is going to do a land acknowledgement.
Good morning, everyone. Thank you, Nellie. Hue, or hello, hue, hame rue. There is a power in our word. The English definition of the word acknowledge is to accept or admit the existence or truth of something. I would like to respectfully acknowledge, accept, and admit the existence, the truth, and the traditional, ancestral, and unceded territories of the Syilx, Secwépemc, and Ktunaxa First Nations, on which I learn, work, love, play, and create, and whose histories, languages, and cultures continue to influence our own. In order to complete this circle of acknowledgement, I ask you to consider the First Nation lands you currently reside on, or enter them in the chat box as well. As we move through our day, we remind ourselves to respect and nurture our sacred relationship to this land, as well as to its First Peoples, past and present. Thank you.
Thank you, Tracy. So I'm going to give you a little bit of background on myself, the scientific director role, as well as the outline for today's first session. So I just want to talk a little bit more about the scientific director role at Rccbc, and I'd like to quote Ray Markham, who says, "The role is to ensure the line of sight between Rccbc and evidence." We recognize that, so Dee Taylor, who is moderating the other session, is my co-partner as a scientific director as well. We both recognize that there's been a tremendous amount of work done by Rccbc over the years, and we're looking to work with them to help highlight that work and share that work through different knowledge translation activities. And then building on this work, we're hoping to create new opportunities for scholarly work, including research, knowledge translation, capacity building, etc. So I would just like to highlight for everyone, you will have access to my email and Dee's email as well. And please feel free to contact Dee or myself if you have questions about the role, or if you have questions about rural health research that then we may be able to direct you in an appropriate direction or have a further discussion. So for today, the purpose of session one is we are going to have brief, rapid style presentations that are designed to inform, engage, and share current rural health research in British Columbia. And so the rapid presentations will be a 7-minute presentation and then a 3-minute question and answer for a total of 10 minutes. Questions and answers for participants, you can type those into the question and answer field or the chat box. I will monitor both of those. And for those who are presenters, please know that I will give you a 1-minute warning so at 6 minutes, a verbal 1-minute warning. And then we will go to question and answer, and I will moderate that question and answer. And we will stick very tightly to the 10-minute timeline. The session will be recorded, this one, and it's already being recorded. And the session A will also be recorded. And so you will have the opportunity to be able to listen to those presentations as well. Now, if there is a particular presentation, you may actually leave this one and go into the other room for that presentation. However you want to make that work is fine. So this is a webinar format, and so your microphones are all muted for the question and answer period. As I suggested, we will be using question and answer and chat features. We will not be able to turn on microphones and take verbal questions given the time frame. We'd like to thank Rccbc and the Joint Standing Committee on Rural Issues for their support of this session. And finally, just want to remind you of session number 2 that will go from 11 to 12:30. And it will be a free-flowing session led by patient and Indigenous and community partners attempting to build bridges between academic researchers and participant partners. So it is a free-flowing session. Tracy, who did our land acknowledgement, will be moderating that session, and so look forward to you attending that as well. So very much different, not as formal, and you will be able to ask your questions directly. And I think that's it. So if we could have Dr. Magda Aguilar share her screen, we are ready to start.
Sure, sorry. Should I share my video as well? Okay.
Yes, please.
Good morning, everyone. I hope you can see at the presentation format and my face as well. I don't see anyone saying they can't, so I'm just going to start. I have the privilege to be the first one this morning. Oh, thank you. I saw some thumbs up, so I imagine you can see me, hear me, and see my slides. So I was just saying that I have the privilege to be the first one this morning, and I hope I don't snooze you back to sleep with my presentation. My name is Magda. I'm a postdoctoral research fellow at UBC. So, and I was speaking to you about this work that is currently going on. We're just about to start data collection. It's funded by BC Support Unit, and it's quite a long title. So next time I will find a shorter title. It's called You Talk, We Listen. We aim to gather knowledge and experience in healthcare decision-making from rural and remote communities in northern BC. I'm speaking with you from one of these buildings that you can see here, very close to Stanley Park. This is unceded territory of the Coast Salish peoples. My name is Squamish and Tsleil-Waututh. But I'm a settler. Very recently, actually, I just moved here a couple of years ago. So I'm still learning a lot about this beautiful land, its peoples, and the research that's been done here. And that comes very close to the work that we are doing with this project. It's about learning from local communities. So as I say, I'm originally from Portugal, and a very small place in the north called Barcelos, mostly known for its for having the biggest market, town market, and so you can buy literally anything there. It's quite fun. I mean, a bit heated now by the pandemic, but we will get back. And so one of the reasons that I'm a health economist, I should have said before, we have a team of rather people with rather diverse backgrounds, but the work it's funded by BC Support Unit, as I said, by the Health Economics Methods Cluster. And I am someone interested in using methods in health economics to see how best we can allocate resources, so public resources like the health budget or other resources like medical personnel, to reduce health inequities. And now, as I was saying before, as I was learning a little bit more about the province, you can see that there is, in general, British Columbia is quite a healthy province, and it's mentioned as such. But there's quite striking differences. And this report is from 2019, but the data is a bit outdated, I find, but it's still relevant, and I know that this trend has continued. And they talk about how the geographic determinant of health is quite striking. And a lot of the data that shows in this report shows that the gap in life expectancy at birth now varies more based on geography than it does by sex, and that British Columbians in Northern and Interior are more likely to die from preventable causes. There's other things. So in this report, most of the health indicators were skewed, and so less favorable for Northern BC. And that sort of drive the scope and the context of this project. And being from a Western country with a big colonization history, and knowing that the methods of economics and the theories are very much based on the mainstream and neoclassic economics that doesn't fit everyone. Our question is really how we can make health economics and the work we do relevant for this territories and for this land and for the people. And acknowledge that I don't know a lot about it. The idea with this project is learning. And so these are the things that I am interested in terms of deciding how to allocate the scarce resources, who decides how to spend this money, and bringing a bit more communities into that decision-making process. So also trying to bring some new theoretical frameworks. They are not new for anyone, but for us in the field of economics, I think. So bringing new perspectives in terms of how knowledge is constructed. So obviously knowledge depends on where you're coming from, and if only the same people create knowledge, you keep learning the same stories. So that's why we're trying to diversify that trend a little bit. Doing a little bit more of participatory research, so trying to not just take the data and go home with it and do whatever, but value local knowledge and have an exchange that is valuable for both. And trying to find new ways, and that comes with the next slide as well, to collect data, to engage with people, and to see if we can make this a little bit more fun. Because when I say I'm a health economist, everyone, it's a bit a little like an icebreaker rather than an icebreaker. So, and I understand why. So we actually have this one session, we're doing Photovoice, which is a method also new for health economics, but not for social sciences, for example, of collecting data and insight discussions through photography. And it's the participants that take the photographs and drive the data collection and drive also the discussion and the coding of the data. So the researcher kind of stands back and learns from them. It's also quite nice because the photography, I mean, we had planned with this project to travel a lot, and for me to be able to see places and people face to face, and the rest of the team as well. But because of the pandemic, we can't do that. And so the photographs hopefully will do that sort of exchange a little bit for now. And so we are working with, I'm just conscious of time now because I see some faces.
Yeah, you have 1 minute.
Okay, I'm almost there. So we have a professional photographer and Jasmine Thomas, which comes with the Cyclist Nation, who has done a Photovoice project at UNBC, facilitating. And we also have focus groups and interviews coming up this month. So this will be a bit more traditional type of data collection. If you are interested in giving us feedback or participating in the sessions that are coming up tomorrow, next week, there will be later sessions in March also that you can get involved in. These are the nice people that you might be in touch with. So Magda, we have two more researchers, Mark and Chloe from UNBC, Teresa Healy at UNBC, Lara Frederick and John Grogan are our patient partners. I know John is picking as well in the audience, as is Mark and Chloe. We're also trying to find a collaborating with the Health Hearts Research Center based at Prince George. And I always happy to collaborate and learn more and get in touch. So yeah, keep in touch and thank you for your time.
Thank you, Magda. Do we have any questions for Magda?
Nellie, I see there is one question in the chat if you want to take a peek.
Okay. So since people in interior and northern regions are more likely to die from preventable disease, what is the chance of educating these regions on the importance of preventative health?
That's a great question. Thank you, whoever posted. I am not an expert in terms of health education, but I am very interested, and I did part of my work is also as a CIHR research fellow with BC Ministry of Health in the Public Health Department. So it's a lot about prevention, and I value a lot that resources are more allocated to preventive rather than curing or treating. So trying to go before things are already on that downline. But I think the issues sometimes a lot about resources, and I think it is good to think about, investing in education and preventive, but I think the issues with Northern and Interior are also related to being areas that are under-resourced, and there's kind of a lot of the funding is centralized in Vancouver, Victoria, and so the more urban settings, and I find that anyway, other ways of distributing the health resources might be also helpful as well. And as you're saying, like very likely towards preventive care.
Great. Thanks, Magda.
Thank you.
Just in response to that too, I think we need to think about the social determinants of health, which I think you alluded to, is access to resources. And we know that people who live in some of these areas also have lower education, lower income. And so those can be also definite impacts on prevention as well. So I think we will move on to our next presenter, and that will be Kayla. So Kayla, can you start sharing your screen?
Yeah, I'm gonna set this up. All right, can you guys see my slide properly?
Yes, we can.
Perfect. All right. Okay, so hi everyone. I'm so glad to be able to connect with you all today. And so thank you to the Rccbc for organizing this event for all of us. My name is Kayla and I'm a third-year law student. And I work with the Center for Rural Health Research out of UBC. The project that I'm going to discuss with you today is really just one of several projects that the Center for Rural Health Research is currently involved in, and you're actually going to hear about several of these other projects throughout the day in this room. But in this project that I'm going to discuss with you, we're working to create a community-based toolkit for investigating legal and advocacy approaches to improve access to healthcare for rural and remote communities in BC. And just before getting started, I wanted to quickly express that nothing about this project is meant to be adversarial in any way. Rather, we're just trying to help improve the situation of access to healthcare for rural and remote communities. And our attempts to do this include sharing information on health commitments in Canada and helping to strengthen the capacity of using these commitments to promote social change. So the Rural Evidence Review is a project that's run by the Center, and it works with rural citizen patients to provide valuable evidence for rural healthcare planning in BC. So part of these efforts can be seen in the Outreach Survey Project. And while this survey project is not the focal point of this presentation, it sets the stage for why we felt the need to embark on creating this toolkit that I'm presenting today. And so because of that, I will just briefly explain what the survey entailed. So this was an online survey. It was initiated in 2018, and it aimed to capture the voices of rural citizens, patients, and communities in terms of their needs, priorities, and perspectives for healthcare. So the survey was sent out to rural and remote communities across the province. And by July 2019, we'd gathered nearly 1,500 responses coming from over 200 communities across the province. And so the survey asked people to respond to a variety of questions, but importantly, we asked, what are the most important healthcare priorities in your community and why? And after carefully reading through all the responses that we received, there was this really overwhelming theme that came through in the voices of those responding to the survey. And that was that citizens feel as though there's a lack of appropriate access to healthcare in their rural and remote community across BC. And so this is just one quote that came out of the survey responses from the rural communities that I wanted to share because I felt it really represented this message of a lack of access that came through in their responses. So this one reads, we're a minimum 4 hours from the next hospital or specialized care, and there's no Greyhound or other public transit. And of course, this is just one of the many responses that we gathered that shared the same concern. The issue is that Canada has made commitments towards the health of its citizens, yet we see that rural Canadians continue to report these inadequate levels of access to healthcare and significant difficulties when attempting to access care. So there's both domestic and international legislation that exists to protect the health and access to care of Canadians. And examples of these sources that we know of include the Canada Health Act, international covenants that protect the international right to health, and other sources of human rights protection that relate to people's health and well-being. And some of these documents even include mention of the concept of accessibility of healthcare. So there are statements that include, mentioning that accessibility means that medical services need to be within safe physical reach, including in rural areas, or statements that say that medical care needs to be accessible without financial or other barriers. And so what we can conclude just quickly from these commitments is that, on a first front, Canada has expressed, through several different means, an understanding of the importance of access to healthcare. And these statements carry weight in that they reflect the importance that Canada sees in helping to protect and promote the health of its citizens. But as I mentioned before, despite having these commitments, we continue to hear from rural and remote community members that they don't have proper access to the healthcare services that are needed or necessary to maintain their health. And so based on the priorities from rural community members that we gathered through the outreach survey, we're currently working on this toolkit. So it's a community-based toolkit for investigating legal and advocacy approaches to improve access to healthcare for rural and remote BC communities. Our current plan for what we want to include in the toolkit is the following. So first, we want to bring attention or continue to bring attention to the reality of access to healthcare in rural BC. So this will be done by highlighting the data that we collected through the outreach survey and other means that the group has to communicate with these rural communities. And we see in literature coming from public health workers from around the world to collaborate with rural communities on access to healthcare issues. We see that they often mention that bringing attention to the issues being faced by rural citizens when trying to access healthcare is a strong means of understanding and highlighting the gaps that exist between a country's health commitments on one hand and the reality being faced by community members on the ground. The second,
1 minute left.
1 minute, perfect, thank you. The second section will be an explanation of these legal health commitments. And so to create this section, we're conducting research on domestic and international laws relating to health, as well as human rights supporting health. And we're also looking into other legislation or commitments that relate to health determinants, as well as access to or quality of healthcare for Canadians. And we're then translating these commitments into language that's easier to understand and explaining, what it is that these commitments actually mean to us as Canadians. And then part of the section is also going to include an analysis of what is it that may be contributing towards this gap that we see between the commitments that exist and the realities of rural Canadians. And then lastly, we want to include a section on exploring the avenues that are available to advocate for change. So what is it that can be done on an advocacy front to ensure health commitments are respected rurally? Or what is it that can be done to get public health systems to be more responsive to rural community needs? And the overall mission of the toolkit is to facilitate the use of the law as a tool for social change in order to translate the communicated needs and priorities of rural patients into actionable change and policy at the community level. And just a quick last slide is essentially this toolkit is for rural and remote community members, healthcare workers working across the province, and really anyone else wanting to help advocate. And so as we continue to create this toolkit, we want to continue to gather the perspectives of rural citizens and really any other member of the public. So just in an effort to help improve the usability of the toolkit and ensure it continues to meet people's needs. So if you have any comments, feedback, or questions, please don't hesitate to reach out to me at my email over here. And that's all. Thank you so much.
Thank you, Kayla. Interesting presentation. We have a minute and a half here for a couple of quick questions. There's a comment in the chat box. Thanks so much for the presentation. How will you be sharing the toolkit with communities who participated in the survey?
Yeah, so there are other people on the call who may also be able to contribute towards this, but my understanding is that we do have really strong communication with many of the communities who had participated in responding to the survey. And so we will be using those avenues to get these results or this toolkit back to those communities who had taken the time really to send us all this really rich information on their reality for access to care. And we'll also be sharing it on our website and on our Twitter page, and just hoping to make sure that it gets into the hands of people who could hopefully really benefit from having this information.
Okay, thank you, Kayla. There was another comment, and not specifically related to your presentation, Kayla, but in general, is a definition of rural. And that people in Vancouver sometimes think that Surrey is rural. And so we definitely need to think about defining what rural means. So another perhaps piece of the toolkit as well.
That's great. Thank you so much. I'll note that down.
Okay, good. Thank you so much. And we are now moving to Kelly Hadfield.
Good morning, just sharing screen. Can everyone see that okay?
You might want to just put it in presentation mode. Yeah, good, wonderful, thanks.
So good morning. I'm going to try to get through this in the time, so apologies if I speak a little quickly. I'm Kelly Hadfield. I'm a second-year family practice resident in the Strathcona site. I'm joining you from the unceded traditional territory of the Weebakay, Weebakam, and Quechua First Nations. Today I'm talking to you about a global health project that's supported by the Rccbc's Rural Global Health Partnership Initiative. It's a collaboration between Ghana Health Services, a Canadian charity called Ghana Medical Help, and members from the Canadian Medical and Biological Engineering Society. In terms of conflicts, I am the founder and executive director of the Canadian charity Ghana Medical Help. It's a 100% volunteer-run organization. I have no stipend or salary from it, and there's no personal financial gain from this project or any associated research. Now, if you don't know, because many don't, Ghana is a West African country. It's a very stable democratic country, and it's organized into regions as we have provinces. Now, very similar to Canada, because its southern border is situated along the coastline where trading routes developed, its economic centers are all concentrated in the south. And as you move north from up the country, there's a dramatic diffusion of resources, of infrastructure, and that really creates and reinforces disparities in health status. So as you go across the north and you see the rural district hospitals, they're abounding with equipment graveyards, which really impairs the ability of healthcare workers to do their basic jobs. The few biomedical engineers present lack the training opportunities that their southern counterparts get. They lack basic tools. The hospitals can't provide them for them. So if they need, say, a screwdriver, they have to buy it with their own pocket money. And there's a lack of standardized infrastructure between hospitals. They very much operate in silos. So Ghana Medical Help in 2009 did a pilot project that took 13 newly stationed engineers to the north. We gave them 2 days of training, and we gave them all basic toolkits, and then we did an evaluation afterwards. and all felt great benefit by receiving this training. 92% found it improved their work morale. 2/3 said it actually influenced their decision to continue working and living in the North as opposed to moving south. All use their engineering toolkits daily as opposed to hourly or monthly or weekly. And most of the 83% wanted to continue participating in an online program. So we developed the goal to expand this pilot into a larger project, really with the mindset to improve the basic quality of healthcare for over 5 million people living in the most underserved region of this country. And by doing so, gain a better understanding of how investing in rural health infrastructure in low and middle income countries can translate to improved health outcomes, as well as cost savings, which can inform local decision-making in the future and establish a global network of peer biomedical engineers. Because as we know, isolated health workers feel very empowered when they have these networks, and that helps mitigate burnout, improve morale, and improve retention. So we developed this project, and ultimately it comes down to tools, training, and infrastructure. So fun year to have a new project come up. So at the end of April, we had planned a 3-day training conference for all biomedical engineers in the northernmost 3 regions. At this conference, we were going to give toolkits to the engineers that have none at their hospital. And after the conference, we were going to continue with an online learning platform for shared learning and network building, as well as we were going to, after the conference, start with the first ever standardized inventory database with standardized nomenclature and an asset tagging system for all main hospital equipment. And then enter the pandemic, and all of these areas got affected. So in March, we realized we were going to have to cancel the conference at the end of April and thus defer the tools and the infrastructure components of this project. But when it came to training, there was actually a lot of urgency in Ghana amongst the engineers for training, because they were told to set up these COVID wards, but they actually didn't know very much about COVID at the time. So we actually ramped up the online training component of this project a month early and started actually with a COVID-related webinar. And we made them much more webinar focused than we were originally going to. So we are currently 6 months into a 12-month pilot of these online training webinars. We have them about every 6 weeks, and they're open to all biomedical engineers from Ghana, as opposed to just the northern-based ones that we originally intended, because really it was really pertinent information in the context of a pandemic to get this training disseminated across. The webinars are all recorded and then posted on the Ghana Medical Health website and YouTube channel for free access to all engineers. And that's been great. For example, the COVID ones had over 200 views. We've now done these 5 webinars, and at the end we do an evaluation. So just to have a little look at the trends that we're seeing, the number of participants range from 20 to 50 in a given webinar, and the geographic kind of location is 5 to 7 regions. So from the very northern to southern borders across Ghana, we're getting engineers coming in and participating, which is excellent. We're really seeing that the content that we're delivering is quite relevant in meeting their learning needs, which is great, and that we're good at incorporating an evidence-based approach into that. And we were curious how Zoom would work out as the medium, and it's been doing a good job based on the feedback. So that's great too. One area that we've really seen to remember to incorporate is including stimulating questions. Our most highly rated and highly attended webinar was one where it was all actually them having a shared discussion and teaching each other unique troubleshooting solutions to common problems. And those are always really the webinars that people get the most out of. So remembering that and ensuring that we incorporate that as much as possible. And then in terms of desired future learning topics, it always comes up that repairs of specific items. And of course, we can't do the hands-on component, which is hard when you're talking about engineers. Well, we've been coming up with creative solutions to mitigate that. They're just taking a little bit more time to set up. So what's next in terms of training? We're going to continue the 12-month webinar pilot, then conduct an overall project evaluation. In terms of the toolkits, we're now rolling out a pilot Ghana-wide toolkit application system. It'll be GMH run, and it'll be using local suppliers. Needs assessments have determined the toolkit content, and we're opening it to all biomedical engineers. Originally, it was just the North, but since the training is going to all medical engineers,
You have a minute left.
Thank you. It makes sense this is as well. And so we're using a triaging system to determine who gets what when. And then of course, we'll be doing an assessment on this. And then in January, we're going to start building this first ever standardized inventory database with standardized nomenclature and barcode tags for all main hospital equipment. Ghana Health Services is, of course, is very involved in all 3 of these components, and especially in taking ownership of this one. It'll be piloted in a sample of hospitals across the North, and we'll do data collection, which if you're interested afterwards, you can read about here. And hopefully we're trying to learn about, through this work, how to effectively create training and infrastructure opportunities in rural and remote communities, which of course is very relevant in Canada, which has similar disparities in health status, resource distribution, and infrastructure. So hopefully this can help inform other key workers and in the end help reduce health inequities worldwide through disseminating the findings of this project. So I just want to say thank you to the RCRHX today for inviting me to speak, our RCCBC for their support, our Ghana Health Service partners, especially Mr. Zonziana, Dr. Bill Gentles and Martin Poulet from the CMBES, who were very much incredible leaders of this project, the Upper East and Upper West regional partners and engineering colleagues, and Dr. Dominic Akatiba, especially from the Ghana Medical Health team, but really all of our partners there. So thank you. And are there any questions? I included these as well in case anyone was interested afterwards, just an interesting comparison stats, but I did not have that much time, so apologies.
Thank you. Well done.
Thanks.
We have a couple of minutes for questions. Thank you for this. I may have missed this detail. Curious about any challenges in delivering web-based training in remote areas.
Yes, so in Ghana, there's far better telecommunications infrastructure in most developing countries than I find in Canada. It's really, really very frustrating on the island that half the island doesn't have the ability to have internet or a cell phone. In Ghana, that's set up, but there's big fluctuations in the day-to-day in terms of the usability of that telecommunications. So there still are big issues with people being able to connect in. So we find that recording the videos and then just making sure they're very freely accessible and that is well known is really the way we've been able to mitigate that so that nobody misses out because they can't attend a 2-hour period of a work day, really. Communication obviously is another barrier, but we use a lot of local trainers. It's a very Ghanaian-led and embedded project. So yeah. Thank you very much for inviting me to speak today. If anyone's interested in getting involved with this project, please feel free to give me a shout.
And certainly having people involved locally makes it much more sustainable, doesn't it?
Yeah.
Yeah. Wonderful. Thank you. Our next presenter is Tanya.
Hello. Oh, I don't think I'm sharing my screen yet. Just a second here. All right. I think I'm, oh, sorry. We did practice this ahead of time. It is just showing up a little bit differently than before. Are you seeing my play screen or are you seeing everything?
We see everything. There you go.
Perfect. All right. So the presentation I'll be doing today is Evidence-Based Support for Community Outreach Worker Program in rural British Columbia, Canada. Our authors and affiliations I have here up on the screen: Dr. Isabella Celeste, Colleen Black, Susan Brown, and Dr. Ella Monroe, myself, Tanya Takers, I'm a nurse practitioner in Princeton, BC, Jenny Pedwell, who is one of our community workers, and Erin Fergon with the Division of Family Practice. And our affiliations were with South Okanagan's Similkameen Division of Family Practice and the Interior Health Authority, as well as One Sky Services, who held the contract for the community worker. Oh, these are my 2019 slides. Oh, there we go, much more appropriate for 2020. All right. The Community Worker Program was started in Princeton in 2015 as a response to disparities for clients who are unable to navigate the health and social systems and programs for themselves. Essentially, there's just too much red tape. This program allows primary care providers, so family doctors, nurse practitioners, to support their clients with psychosocial needs by referring them to a community worker. Community workers connect clients with community services and programs such as day programs, skills centers, lawyers, food banks, tax preparation, which is key if you're trying to set up your MSP, parental supports, children's programs, rehabilitation, and they advocate for clients with government agencies. So this includes the Ministry of Health. As well, community workers help clients transition from home to facilities, assess needs and attend physician-client appointments, nurse practitioner-client appointments, if necessary. So since the program's inception, community workers have been integrated as part of the patient medical home team that supports team-based care in Princeton. The research objectives were to depict the program structure within the community context, to determine the barriers and facilitators to successful implementation, as well as to highlight potential returns on investment as we're trying to stabilize our community worker within our community. The research questions are, what is the role of the community worker? And should they be funded as part of the patient medical home, which has been key as we've been rolling out PCNs within BC. So our research was mixed methodology, quantitative and qualitative. The quantitative components were the monthly community worker reports, as well as looking at the Division of Family Practice, as well as Sakai, that's the contractor who held the community worker position, their fiscal reports, the community worker service log, electronic medical records from the local clinic, IH Strategic Information Unit, as well as looking at the qualitative components, which were the primary care provider and integrated team focus, information and, I can only half see my slides, information and consulting sessions and feedback from the community worker themselves. So when we look at our results, the results for our first objective, which if you'll remember was the program structure within the community context, we found that so the community workers worked a 16-hour week, which turned into a 64-hour month. The community worker on average would support 15 clients, provide 28 visits, execute 10 referrals to community resources, and participate in 4 team-based care meetings. And these occurred weekly. And the program costs about $26,000 per year to run. When we look at the results of Objective 2, the key facilitators to implementation, one of the key facilitators was availability of resources to connect clients with. So if you don't have the resources within the community, there's nowhere to connect the client. Stability of financial support, which has been key and a little bit piecemeal. The primary care provider support, so family physician and nurse practitioner referrals and support of the community worker in doing their job. Integration with the primary medical home team through EMR and meetings. So the community worker had access to our electronic medical record in order to receive referrals, tasks, updates. And a nimble and adaptive structure within the program, but also for the community worker within their personality. They were much more successful if they were able to be quite nimble and adaptive with not only the client, but the program and the different types of referrals. Role definition and clarity, and a strong trusting relationship among the community worker, the client, and the provider. Objective 3, potential returns on investment. So this one was key, improve primary care provider wellness and job satisfaction. We really heard from the nurse practitioners and the physicians that it was a great gift to be able to do their job within their appointment time and not be trying to do a lot of this navigating of social systems. And then they were also able to help the client move their health forward rather than always trying to figure out their MSP, whatever the concern might be, navigate how to access a food bank. Also improved appropriate use of healthcare systems. So it facilitated 142 attachments to providers, reduced client emergency department use by 41%, and actually increased the primary care provider visits.
A minute left.
Thank you. Which was really key because it meant people were utilizing their NP or physician visits in a correct way. It also improved community networks and integration. And these are some of the community networks that were accessed by the community worker. So I'll just highlight the first 3: financial, government services, and home and community care. So the bottom line is clients enrolled in the community worker program do not fit into already predefined services offered by the health authority. They often require more supports than those who do fit into these predefined categories. And with the current healthcare system transformation in BC, it is imperative that the value of the community worker be recognized and funded as we're looking at PCN rollout within rural communities. Our funding sources were the South Okanagan Similkameen Division of Family Practice, as well as Interior Health. And I'll just end with pictures of a few of our different community workers. Any questions?
Thank you, Tanya. Are there any questions for Tanya? There is a question in the chat box, which is not totally related, but maybe you want to comment on, Tanya. Is anything being done to create a collaborative approach with various stakeholders to rural BC rather than everyone working in their own silo?
Yeah, and I think I could take that question a few ways, but one has been writing up the community worker paper and having it published so that hopefully we are disseminating some of this knowledge. And we have moved the community worker position into a neighboring community to see if we can also have some of the good results and establish the community worker there. And one of the barriers actually to that has been the lack of recognition for roles like the community worker within the PCN rollouts, the primary care network rollout, because currently these types of positions aren't being funded. And so it really takes a lot of community buy-in to piecemeal this funding together.
Yeah, good approaches, and also speaking around the structures that that limit such different innovative approaches. I think also I can comment that the event such as today allows also to be able to share different components of innovative projects and their results, and so another way to share.
Yeah,
and then we have a comment from Ed and Ninka with regards to excellent presentation and speaking from experience about the value of the community worker role.
Absolutely, and shout out to Ed and Yanka, who have been championing the growth of rural healthcare and particularly supporting in Princeton.
I agree. Good, thank you, Tanya. We're going to move on to Sally.
Okay, so hopefully that's working and hopefully everybody can hear me.
Yeah, all's good.
Is that right? Okay. So my name is Sally. I'm speaking from the unceded territory of the Comox First Nation in Cumberland. I'm sorry about my video. My husband is significantly taller than me, so I'm using his office today. So the subject of our research study is understanding the experience of rural maternity care providers during the COVID-19 response in BC. I'll be presenting, but my partners in research are our research supervisor, Dr. Trina Fife, Paige Haberstock, who's a fellow fourth-year medical student at the Northern Medical Program, and our research assistant, Anne McGlattery, who's a second-year medical student. Here we go. So just to begin, a quick outline of our funding sources and some disclaimers here. So we have so far received some funding from the Rural Health Services Research Network. We do have some funding pending from the Canadian Foundation for Women's Health, fingers crossed. And while we've obtained some...
It's just a bit difficult to hear you at times. Just maybe if you could speak up, thanks.
Okay, I'll try and speak up. I am getting a word that my internet connection is unstable, so fingers crossed here. Okay, so while we've obtained some approval to conduct interviews within Island Health, we continue to wait for approval from Northern Health. We also await the results of an ethics amendment to expand our study to the Comox Valley. Our research project is currently affiliated with the UBC Faculty of Medicine, UNBC, as well as Island Health, and we have no conflicts of interest to declare. Okay, so this project came about as a result of work during my clerkship year with the Cowichan Maternity Group in Duncan in the early days of the COVID-19 pandemic. So like many care teams, the group was striving to rapidly adjust protocols to accommodate the new situation. And it was my role to consolidate all the emerging guidelines and clinic decisions on protocols into one document, which was sort of user-friendly for the physicians. And that gave me access to a number of stakeholder meetings with physicians, midwives, anyone involved in maternity care in Cowichan. And so I observed a lot of decision-making taking place at that point. And that role inspired a literature review by myself and my fellow fourth-year student Paige on pandemic planning in Canada. So we looked at SARS and H1N1, as well as the history of changes since those outbreaks. And what we found was that while improvements have been made in pandemic planning on both the national and provincial scale, since SARS, both SARS and H1N1 left frontline physicians feeling fairly unsupported. So a lot of themes in the literature included lack of clarity on guidelines, poor connections to public health, equipment shortages, and kind of poor communication overall. And since then, funding efforts and institutional changes have been made in order to try and address all these deficits, but obviously they haven't been tested until the current pandemic. So we also noted that for all the previous outbreak experiences, there was a lack of BC-specific literature on the experiences of frontline physicians, and that's likely because most of the hard-hit areas were in Ontario and Quebec. So as a result of this literature review, we thought that an exploration of frontline experiences during the current pandemic would add in a meaningful way. As a result of our work with maternity physicians specifically, as well as our geographic bases in rural regions. So Paige and our supervisor Trina are in Prince George, and myself, I was in the Cowichan Valley. And our research question became, what are the experiences of rural maternity care providers in responding to the COVID-19 pandemic at the local level? So in order to facilitate the study, we applied and received ethics approval for both of these communities. Okay. And our methodology here, our approach to inquiry is informed by interpretive description, which is an applied health research approach. It's used frequently in nursing. We're conducting semi-structured interviews that ask providers about their role and experience in providing care during the pandemic. So for example, some of our questions include, what are the processes or protocols that you engaged in or were developed as a result of the pandemic? And what were the strengths of the local response? Do you have any suggestions for improvement? Questions similar to that. So the context of these interviews is semi-rural, with both the Cowichan Valley and Prince George. They're classified as Class C communities according to the Rural Service Agreement. So the providers surveyed include midwives, OB-GYNs, GPs, nurse practitioners, anybody involved in maternity care. Our approach to participant recruitment has been to use existing contact networks as well as snowballing, so asking participants to forward requests for participation onwards. Okay. And so I don't have any results for you yet. The study is ongoing. We just started interviews in late October. We've completed 3 interviews so far, and we do require more participants.
You have a minute, Sally.
To track down physicians and get a piece of their time. So we're expanding to the Comox Valley pending ethics approval. And then going forward, we'll continue to engage and recruit participants. We'll analyze our data, and hopefully we'll engage in meaningful knowledge translation via both publication and presentation at future conferences. We also plan to include a stakeholder report. Hopefully the study can be a meaningful stepping off point for future research in other communities, or as a comparison between the rural physician experience and that of physicians at larger centers. And then I have a reference slide and questions.
Thank you, Sally. Does anyone have any questions for Sally? Sally, do you have any thoughts around you know, where this research might take you, might end up, like from a results perspective or moving forward?
Well, I tried to not have too many preconceived notions about what the results of the interviews would yield, but I suppose just from the 3 we've done so far, I've been quite surprised by the comments on the strengths of rural centers, just with sort of group cohesion and everybody knows everybody, so decisions, there's some opinion that decisions are actually made more quickly. So that's been interesting. It's hard not to think that the lack of resources in rural communities would affect things. But yeah, I'm ready to be surprised.
Good, wonderful. Also, I think it would be interesting to see the patient perspective as well, right?
Exactly. And I think I kind of came from this from a unique perspective. I was pregnant during the pandemic and recently had a baby. So I was very much experiencing the patient perspective. So maybe that's why I chose to do the opposite.
Great. There is some work being done by Marie Tarrant from UBC Okanagan, looking at patient perspectives around delivery, being pregnant, and postpartum following it during this time. So that might, I think they're not limiting it to rural, but including rural as well.
Yeah, that's great.
Great, thanks. And we next have up Jude.
Hi, sorry, just getting organized here. Can you see my screen?
Yeah, can you just put it in? Yeah, great, wonderful. Thanks, Jude.
Okay, thanks so much. And hi, Nellie, thanks for orchestrating this, and nice to see a lot of familiar names and faces. So looking forward to the whole day, actually. And what I'm going to be talking about in this presentation is actually a little bit of a deconstruction of evidence, especially as it's applied to health, rural health services research evaluation. And I'm specifically going to be talking, I'm presenting from the traditional territory of the Coast Salish people, specifically it's Salwat Nation on Salt Spring Island, and have been here for about 20 years and delighted to continue living here. So I'm going to be talking specifically about a project called the Rural Surgical and Obstetrical Network project, and it was developed and funded through the Joint Standing Committee on Rural Issues as a way to enhance and sustain rural surgical and obstetrical networks, or surgical programs of the smallish size that, as we know in BC, have been pretty much hanging by a thread for the past couple of years due to attrition, due to a whole bunch of reasons. And it was deemed appropriate and helpful to try and find ways of system interventions to sustain these services. We have a 5-year funding envelope. We're about halfway through, and the system interventions include different modalities of funding for increased scope and volume at a local level, really fancy remote presence technology that links the regional referral center or even tertiary centers with the rural sites, funding for clinical coaching and training, CQI, and what I'm going to be talking about today is the evaluation of this. So the evaluation itself has a couple of streams. And so first, of course, we're looking at the local and regional health outcomes. So we look at as one measure of quality in surgical care, what the health outcomes are at a facilities level and what there are also at a catchment level. And I won't be talking too much about this. I know Stefan's going to be explaining catchments later on, but it's basically the surrounding catchment for a hospital to look at how that population is doing regardless of where they have their procedure. And it reduces referral bias. We're also looking at network structure and function. So we've put a lot into the notion of networks and regional alliances to sustain care between regional referral centers and smaller sites. So we have to look at how well that's working. Do networks actually lead to stronger, regional rural health services? So we're doing that a whole bunch of different ways. And of course, cost effectiveness. So we're looking at how to measure cost effectiveness, but doing it within a comprehensive framework. So we're looking at direct costs, system costs, cost shifting, and also out-of-pocket costs to patients who may need to travel for care. So this is all encapsulated in an approach to the evaluation of shared measures. And basically that's making sure that the key stakeholders and key right holders who might be receiving the services or involved in planning the services or providing the services has a say in the kind of evaluation we're doing, and most importantly, tells us what's important to measure. And as you all could anticipate, sometimes what we think of as researchers or evaluators as important isn't necessarily important to people on the ground. So this was a key values proposition underscoring the approach to the evaluation for the arson networks. So we've done this in a couple of different ways, and I'll just give you some examples of how we're doing this. So first of all is making sure we're looking at the priority outcomes. So we've done a whack of focus groups and interviews with people in communities, in the 8 RSON communities across Interior Health, Northern BC, and now adding on Island Health communities as well. So getting pre-COVID, being on the ground, having focus groups and interviews and talking to as many people we can. And out of that, we have extracted the things that we think are important to measure based on what the focus groups participants have told us. In terms of the population health outcomes, this is, it's really tricky to be evaluating health outcomes of rural surgical services because of 2 main reasons. First of all, there's low procedural volume, but it's also across a generalist skill set. So there's lots of procedures being done, not heaps and loads of all of them. And so how do we know what's important to measure through a rural lens? Well, we've done a Delphi survey process where, just an example for general surgical measures, where we asked key stakeholders and people who are engaged in providing services and evaluating services what they think is important. So we use that as our framing what we're going to be looking at for the population health outcomes through Pop Data BC. And we're doing both administrative outcomes, but also from the ground up. And one of our streams in the arson project is CQI, so continuous quality improvement at a community level. So we're juxtaposing what we're getting from the administrative data with what we're seeing on the ground. And I think near and dear to most of our hearts is making sure that we have a sense of what the Indigenous priorities are. There's a very big conflation of rural and Indigenous in many of these communities. So we've spent time and really reached out to be informed of what would be appropriate in an Indigenous engagement strategy. So this is just how we can appropriately, through the Rural Surgical Obstetrical Networks program, engage Indigenous communities. And we've been so lucky to have a fabulous student, Sela Rogan, who's been working with us on this. So a lot of this is her work, but just in brief, the Indigenous engagement approach is
Do you have a minute?
Thank you. I'm almost done. A couple of key principles. And the first one is making sure that we build relationships with community. And we've been doing this, we've been doing this for certainly the past year, I think a little bit longer now, with, of course, the challenge of COVID intervening there, but allowing the communities to articulate the direction that we go in. The other key principle is making sure we're grounding ourselves in principles of cultural safety and humility. And that is definitely an ongoing process, but we have a strong commitment to inform ourselves as much as possible and again, take direction from the community. We are grounding this in the commitment to advancing reconciliation. And many communities have mentioned, of course, that returning or reclaiming birth on traditional territory is part of the reconciliation process for them. So really focusing on that. as well as valuing community knowledge in telling us what they think is important about surgical services. And it's interesting, it's not the health outcomes part, it's the feelings of respect they have when going to access a service is what we're hearing from communities. And of course, respecting Indigenous data governance through working out agreements if they're desired through OCAP principles. So that's kind of our guiding principles. And I'm sorry, I can't go into any more depth right now, but that's directing how we're engaging with our Indigenous partners in this project. And I will open it for questions.
Thanks, Jude. We have a couple of minutes for questions, folks. So maybe Jude, I'll ask a quick question. What's sort of your next steps with this?
Yeah, so we're just getting our administrative data from Pop Data BC. So we're going to be evaluating that in a collaborative framework where we're going to be sharing it out with our clinical advisory committee for arson, but also key people in the communities who are actually on the ground providing services, but also with all of the streams. So it's an iterative approach where we get a bit of findings, we bring it back to communities or administrators or whatever, and they inform the next step. So we're going to be continuing doing that for the next 2.5 years.
That sounds wonderful. That iterative approach is so important. Great. I don't see any other questions. Oh, here's a question from Rita. Why can't Indigenous and rural BC take a collaborative approach to some of the issues?
So in many communities, they absolutely do. If there's an Indigenous nation that's adjacent to or contiguous with a non-Indigenous community, they often plan services together. And we know, of course, that we need a key number of procedural events to happen. And often it's combined with both parts of the community. So they're not separate and distinct at all. What I was emphasizing here was our distinct mechanism of outreach to Indigenous communities.
Okay, thank you very much, Jude. We're going to move on to April. And after April, we're going to take a 3-minute stretch break. We have a little bit of time in between. So.
Hello, I'm going to be sharing with Jude actually. I'm just going to bring up our slide.
Great, ready to go.
There we go. And Jude's going to start.
Yeah, I'm just going to start us off. We're going to be, or mostly April is going to be talking about a super innovative project that I'm really excited about around rural citizen patient engagement and development of resources to support rural women in the postpartum period. So we're working in Golden specifically. And April, if you can advance the slide. And we'll gratefully acknowledge the traditional unceded Indigenous territory of Coast Salish Swat Nation that I'm on Salt Spring Island, and the Tunaxa and Sikswamic Nation, and home of the Métis Nation Columbia River Society that April is coming in from in Golden, BC. So the project, if you can flip forward, April, the project that we're talking about is funded by the Michael Smith Foundation for Health Research, and it's a patient partner engaged P2P project. And I guess just the little bit of background that I want to provide is I was in Golden doing other work with shared care, and we had a community forum about what citizen patients, what birthing people wanted in a maternity service. And April was at the forum and brought up so cogently the issue of making sure we focus on perinatal mental health in the community, and how difficult it is sometimes because of being stigmatized or not having access to services to get the services that are needed. And she was so compelling, I made sure that we met up afterwards and said, you know what, you're right on the mark. What can we do together to work on the project? So if you can advance advance, April, we got funding from the Michael Smith Foundation to engage in citizen-patient, I guess, discussion about what's important for them in the perinatal period. And I'll turn it over to you, April. Thank you.
Thanks for having me today. So yes, I'm April. I'm a single mom, and I identify as a Métis woman, and I'm low income, and I also have a mental health issue. So when I became pregnant, it was a big concern of mine of how to prepare for the postpartum period, because I was going to be 70% more likely to develop postpartum depression. And in our community, we have very limited number of providers offering mental health services, which is crazy because our town actually has a lot compared to other rural places. But we face stigmas and the lack of anonymity in the small communities, and the wait lists are crazy. And also the format for doing that is, it's just weird. Like, you have to fit inside this little box, and if you don't check these boxes, you don't qualify. And a lot of times people who are trying to access help when they are experiencing mental health issues, for myself, will not be completely honest in the beginning, because you're nervous, you're scared of getting stigmatized, and things like that. So what we're finding through our research is that, yes, there is a need for something to plan postpartum that you would do prior to having the child. And we're working on different tools for that, but also peer-to-peer support, like the importance of peer-to-peer support. Like, change needs to happen, but it's not going to come from the current infrastructures that we have. We need to figure out a way to have the ground-up approach where peers of myself, for example, patient citizens, are setting it up. And the challenges that we're finding now is, like, where is that going to sit? Like a peer-to-peer support group, where in the community does that sit? Who funds it? How do we get it going off the ground? How is it going to look? How are we going to target our demographic? Because in the small communities, there's definitely, like, there's a line, right? Like, there's places that people can go that you can get support and hang out, but it's not for people that experience my adversities in life, right? Like, I could go to them, but talking about, like, oh, you went skiing at the ski hill this week, or you got your nails done or your hair done, or things like that. I can't afford to do those types of luxuries, right? So it's just not, there's a place for that, but there's not a place for people like me who are scared to leave their house, who most of the time have to access the food bank, and things like that. And also there's a lack of voice of my representation on the boards, the nonprofit organizations of the community that are setting up funding for these types of programs. So a lot of times there's just not enough structure or focus around it. And so it kind of becomes more of a problem than an actual support. I don't know if that makes sense. I don't want to be rambling. I'm sorry, I'm a bit nervous. But yeah, so we're doing community forums, the snowball sampling, obviously, of key informants within the community. And our interviews are semi-structured. They're kind of becoming a bit more, we're interviewing, like, members of boards, members of, like, say, the food bank, different members of nonprofit organizations. But then also we're interviewing patients that are of a minority, whether it's because they have mental health issues, or it's a visible minority, or just any type of thing like that, where their voice is obviously is key. An integral part of understanding what the peer-to-peer support model needs to look like. And I think that's the beautiful thing of it. We are engaging citizen patients such as myself to design what the support needs to be. We're not telling them what support needs to be. We're actually looking for, thank you. We're actually looking for input on how it would help them. What does that look like? What do you think would be important to include in this? How would you like it to be, you know? So yeah, the system isn't designing it. The people that need it and that need to access it are designing it, but we're using, obviously, fundings of systems for the research to be able to do that. I don't know if that makes any sense, but I'll just wrap it up if there's any questions. Thanks for listening.
Thanks, April. Thanks, Jude. That sounds like a very exciting project.
Yes, it is.
Yeah, there is a question for you, April. Thank you so much for eloquently giving voice to the community client perspective. We have attempted to support the peer-to-peer model through a mom's coffee group and a women's mental health group run by the community, but supported by a mental health worker. Would it be helpful to connect?
I think it's always helpful to connect with like-minded people that are trying to make change systemically, because we need that in more areas than just the mental health. So yeah, definitely, I think that would be great to connect.
So Tanya, if I can get you to connect with April, that would be wonderful. And people's email addresses have been included in the presentation document. Are there any other questions for April or Jude? Pamela, thanks to you for all your time dedicated to improving this. And what would you say is the most surprising finding you learned from your interviews? If you were to give advice for people in healthcare, how should we find brilliant people like you to help us?
That's a good question. Just by listening. If you're doing forums or now that it's online, just truly listen. I got noticed because Jude truly listened, you know? And it's hard for people such as myself, like I have mental illness diagnosed from years of trauma. So I have complex dissociative PTSD, and it's really hard for people like myself to advocate. And then when they do step up, a lot of times it falls on deaf ears. So to just truly listen, like not listen because you're waiting to ask the next question, or not listening because you're trying to get data, listening because you actually want to know what they're saying and that you care, and just have compassion towards what they're saying.
Great. Any other questions? If not, thank you so much, April, for sharing your story and the work that you're involved with Jude. I look forward to connecting with you as well. And we are at this point in time ready for a break. And so I would recommend that people be back at, if we take a 3-minute break, that would take us to about 9:52 according to my computer clock. So if we can be back at 9:55 ready to go. So come back earlier, but ready to go at 9:55. All right. And Stefan, you're up next. Stefan, we'll just wait a couple of minutes or a minute or so and we'll get you going.
Great, that sounds fun, Nellie. I also have Nikki doing a joint presentation, and she's going to be running the slides. So she's
wonderful. So Nikki, if you want to put your slides up, I think we can go ahead and do that now.
Great.
And maybe Nikki, why don't you introduce yourself first, and then I will, and I'll just continue on with my part of the presentation.
Sure. Are we ready to start, or are we waiting a little bit longer?
We're just I told people that we would get started at 9:55, so it is 9:54.
Okay.
You're doing a masterful job of orchestrating this, Nellie. It's very tightly scripted.
Thank you.
I realize I have 210 seconds to speak.
I think we can go ahead and get started, Nikki.
Okay. Great. So we're going to be talking about developing and implementing the Rural Birth Index in BC. I'm Nikki Cairncross. I'm the research coordinator of the project, and I'll let Stefan introduce himself now.
Hi, I'm Stefan Shrabowski. I'm a family physician and health services researcher, and I'm calling in from the traditional territory of the Coast Salish and Tsawut people, and otherwise known as Salt Spring Island.
And I'm joining, I'm joining from the Musqueam, Squamish, and Tsleil-Waututh in Vancouver.
So just to make it more interesting, we're going to be bouncing the mic back and forth. Nikki's controlling the slides. So this is about need. This is about planning health services in response to need, and we all believe that that's the right thing to do. We should have health services in response to need. But our question was, can we actually measure need? Can we actually do it in a way that's objective? And we chose to try and do that for maternity services. The context for this is that there are a lot of closures, as you're probably all aware. And that when we looked into systemic planning, a lot of it looked like it was ad hoc, often the loudest voice in the room with the determinant. And there also wasn't a lot of evidence. So that was where we started in 2009 when we first calculated the Rural Birth Index. Next slide. It's fairly simple. It's based on 3 factors which evolved from an extensive qualitative work and a logic model analysis. How many women birth on average in the catchment area of the facility? How vulnerable are they? We all believe that more services should be provided for those who are more vulnerable. And how far away is the next service? Those are the 3 key factors, and they're not complicated. Next.
So our working hypothesis was when we recalculated the RBI for the 2019 year that we actually thought that the RBI scores would remain relatively stable over time. But what we found was that there was actually a large shift in need, and 27 out of the 42 communities that we looked at had changed more than 10% in their 2009 RBI score. So instead of just keeping the 2 start and end time points, we decided to go back and ask for 10 years worth of data to actually calculate the RBI score on an annual basis to try and understand the trends over time. And I just have a couple of community examples. The community names have been removed because we're not publishing or sharing the specific results yet, but these are actual communities that have been calculated. So first I want to highlight one of the communities that had quite a large increase in level of need. So below you have the years, and you can see each RBI score for 2009 up to 2019. And it's just overlaid with the level of service that population level need. So this community has increased by about 20% over the 10 years. And then I have another example of a community that had quite a decrease in need, quite staggering. So in 2009, the RBI score was 14.3, and now in 2019, it's hovering around 8. So this community has decreased the population need by almost 50%, which is quite staggering in 10 years. And then here's another example of an RBI community that's remained relatively stable over time. So it has hasn't changed much in 10 years. And that's kind of what we thought we were going to see with a lot of the communities. And in fact, there's actually been a lot of change over 10 years. So the annual RBI is a really helpful tool to see when services are really struggling and when they're really growing, and what years that might be happening in. So just wrapping up our implications and next steps, it really provides important insights and sustainability for appropriate maternity service and trends, as well as we're hoping to create a planning framework tool for healthcare decision makers. And we're looking at a few things. We're going to be looking at referral patterns, utilization patterns, interventions at birth like C-section rates and induction rates, and then as well as NICU admissions and preterm birth rates for each community. And then the RBI, of course, complements our current provincial work on the development of the maternity service strategy. So I'll hand it over to Stefan, just in case he'd like to say his final thoughts.
Yeah, I think we're beating Nellie to the 1-minute punch. So I have a couple more comments about this. So the genesis of this project is how can we plan support planners more effectively, and not only can we systematically measure need, we can track it over time based on a 5-year rolling average, and we can demonstrate pretty remarkably that need changes, and consequently the need for services, there may need to be more flexibility, more thoughtful, and we may need to follow the projection outwards and say, okay, what's going to happen in this community? What is happening in this community that's related to need? Why are less mothers having babies in this community than did 10 years ago, for example, or more mothers? And what do we think it'll look like in 10 years?
You do have 1 minute now.
I knew you'd come in, Nellie, with a clear reminder. Yeah, so that's the idea of it. And as Nikki alluded to, we think that if you're a planner trying to make a decision about what to do in a community that's in crisis, as we have often seen with respect to services like maternity services, what do you need to know? Like, what's going to be helpful? Well, need, but also, what are the patterns of referral? Where are the women going now, or where will they be going? What interventions happened in the last while on an annual basis over the past 10 years, and what outcomes? So if there's any questions, we'd be delighted to try and answer them. But thank you for the opportunity to share this.
Thanks, Nikki and Stefan. There are some questions. First question from Kim Williams from Rccbc. The original RBI used need for physician, GP, OB. Will you be looking at how to include midwives as well in your work?
I'm going to tackle that one, Nikki, if you don't mind. We didn't differentiate physicians from midwives. In the communities where there were no surgical section services, where the highest level of service was, or to say the most complicated level of service was surgery, where we had that extra asset. In communities that didn't have surgical services, we didn't differentiate between midwifery served communities, mixed models between midwives and family doctors, or a family doctor nurse model. So that wasn't the case. I do think that there are new model applications that we should search for, or we should understand better, that are midwifery only applications in rural and remote communities. So I think it's a great point.
Okay. Another question from Amanda. Do you have any thoughts about what the impact of COVID might be on RBI scores in these communities?
you know, God knows what the impact of COVID-19 will be on our overall societal patterns of being, you know, they're huge. And I think when you think about, I think about it as positive and negative, and some of the positive impacts are on climate change issues. There's a lot of going on in terms of reducing our fossil fuel reliance. Whether women and families will choose to have babies or not in rural communities is a good question. And I think that's a great question. Again, I don't know the answer to that.
Nikki, any comments?
No comments, but we have talked about just this idea of traveling to give birth in larger hospitals as well during COVID, and how that's going to impact advocating for services in smaller communities as well. So it is on the top of our minds.
Great. And the last question from Kim is about virtual support, and how do you feel that this might influence the RBI and planning around that?
Yeah, so just to kind of circle back slightly, we need our rural communities to do as much as they can. Like, we need to provide as much service at the front lines as is possible, given the needs of the population, the size of the population. So if it's large enough to support a maternity service, it should have one. And if it has one, the more virtually connected they are, the better, so that they feel like they've got somebody to turn to if they need to. And even if they don't use the virtual support, at least they have the possibility that it's like having somebody next to you who's got, you know, that maybe extra knowledge or experience to get you over that stressful moment.
Great, thanks both. And if there are any other additional questions, please contact Stefan and Nikki directly. So Eva and Audrey are next up. Okay, you're ready to go.
Awesome. Good morning, everyone. So Audrey and I are research assistants at the Center for Rural Health Research, and today we're going to be presenting on emerging findings from a qualitative data set around the impact of COVID-19 on the perinatal experiences of rural families. So I think it complements quite nicely the presentation that we had earlier on the understanding the impact of COVID-19 on maternity physicians. And it's also, I think, important to note that this is part of the broader rural and surgical obstetrical networks initiative evaluation, which Jude spoke about earlier. We'd like to disclose that the study is ongoing, so that all the findings that we discussed today that we present are just preliminary analysis of the data. And we would also like to acknowledge that today we're calling in from the unceded and traditional territories of the Coast Salish, Tsleil-Waututh, Musqueam, and Coquitlam nations. So just to give you a little bit of background about the project, the imperative for this study arose in March when we transitioned as a research center to a distributed work environment. And we took a bit of a pause from engaging with clinical care providers in the rural artisan communities, recognizing their constrained capacity to engage in research initiatives. So we wanted to use this opportunity to understand the particular dimensions of the impact of the pandemic on rural communities through the lens of rural women and families who are experiencing the perinatal period. So this includes pregnancy and giving birth and the postpartum period. So in this way, we see our study contributing to the emerging literature on the impact of the pandemic by filling a rural gap. And we've paid particular attention to the kind of biopsychosocial dynamics of the pandemic, which we hope to have captured through rich qualitative interviews and focus groups. In terms of our methodology, the inclusion criteria for the study was any rural citizen patient who was pregnant or gave birth after March 17th, 2020, which is when the province declared a state of emergency. And we recruited participants through our pre-established patient recruitment channels, which include social media pages and local newspapers, as well as our RSON local community coordinators who actually live and work in the rural communities that we're studying. And we used a semi-structured interview guide to probe rural patients about different aspects of their experience during the perinatal period. So, for example, we were interested in hearing about changes in modes of delivery to the care that they received and understanding their perception of changing public health protocols and policies, as well as the overall kind of impact of social isolation on their mental and physical health. So as I mentioned earlier, the study is ongoing, but so far we've conducted 12 interviews and focus groups with patients from 4 rural communities in interior health and 3 rural communities in northern health. So I'll pass it on to Audrey to tell you a little bit about some of the themes that are emerging from our analysis now.
Thanks so much, Ava. Yeah, so I'm going to be talking a little bit about our emerging themes, and we're finding they're not so dissimilar from what other patients report due to the pandemic, but as we add our rural lens, you can see some different dynamics emerging, namely around perception of risk, psychosocial impacts, and care access and perception of quality. So firstly, beginning with perception of risk in rural communities, we can see that some participants actually reported a bit of comfort being in a more distal community further from larger city centers with more COVID cases. Some participants were noting exceptions for those who had partners who were working outside of the home, as well as for some patients who were closer to the Alberta-BC border, so talking about some nervousness around interprovincial travel and outside people coming into the community looking forward to the summer. This was back in May and June, with some increases in tourism in rural communities, things like that. Next slide, please. So our second emergent theme centered around the psychosocial impacts of the pandemic. Participants expressed concern around consistently changing protocols, specifically for our rural context for those patients who were needing to travel to regional centers for certain procedures. So then having to juggle multiple different hospital sites, multiple different protocols at these hospitals, and that just adding to an increase in uncertainty around protocols. Additionally, there was a lack of clarity for participants on current hospital policies, specifically around whether or not their support person would be allowed in the delivery room, and a general loss of support, as you can see in this first quote here, the patient asking, "Who will take care of my children if I'm not comfortable having someone else come into the home while my partner and I are at the hospital?" And these challenges were emphasized especially for participants whose families were overseas or out of province and unable to come and travel due to restrictions and help care for this new family after the delivery. Next slide. So some psychosocial effects continuing, amplification of pre-existing mental health challenges were something we saw. This was exacerbated by the unknowns at the beginning of the pandemic, as well as ongoing social isolation of the birthing person to protect themselves and their families before delivery. Participants also noted the loss of celebrating certain meaningful events like baby showers with their communities, missing out on in-person prenatal parenting classes, as well as even milestones like traveling to shop for baby cribs or other supplies. As well as lastly, they noted some concerns about the impact of social isolation on their other children. So this participant in the second quote notes that her children were allowed to go back to school being in a smaller rural community, but she still did not feel safe sending them back because she was pregnant. So just noting how these concerns impact not only the birthing person, but their children and their partners as well. And then thirdly, our last emerging theme revolves mainly around access to care and perception of care. Overall, patients reported a decrease in the number of in-person visits and an increased shift towards virtual telehealth appointments, both for pre-delivery care as well as for postpartum care. Public health nurse visits moved from home visits to phone calls, that sort of thing. And the second point, so there were some differences in participants' experiences, which just underscore the variability of experience even within a more narrow rural context. For some, changing protocols, faster in and out visits at the doctor's office, it felt maybe impersonal, like a compromise in care. For others, those faster visits felt like a benefit. There were fewer people in the doctor's office, more privacy. So yeah, it depended on the patient's experience. And although definitely in general, patients did note some disappointment around the necessity of these changes because of the pandemic, but across the board, patients were very understanding for the need for these changes, as well as they expressed a lot of appreciation for the flexibility and ongoing compassion of their local care providers, as they also were facing a lot of uncertainty.
Great. So I think we're almost out of time, but I'll just reiterate what Audrey said, and that's that the pandemic has clearly had a differential impact on each rural community and indeed on each rural family, I think. And a lot of what we found is similar to other studies in terms of the broader psychosocial impact of the pandemic, but in particular, we heard that rural citizens are feeling quite isolated during the perinatal period. They have a heightened perception of risk when visitors visit from outside of their community, and the restriction of travel is particularly difficult during this perinatal period as well. So thanks so much for listening, and we'll turn it over to any questions that you might have.
There's one comment question, and we only have a few seconds, 30 seconds. Wonderful presentation. Curious if you had patients speak about positive aspects as well.
Yeah, absolutely. Great question. We did have quite a few participants talk about the kind of unintended positive consequences of the pandemic. And for a lot of patients, that were things like spending more time with their partners who were able to take off time from work or work from home. And also we heard a lot about in the postnatal period, people who were really glad to not have visitors constantly popping in and out as they were kind of adjusting to life with a newborn. So great question.
Great, thank you both. And we will move on. If there are additional questions, please contact Eva and Audrey directly. So we have Pamela and Marie. Okay, you're ready to start.
Great. Well, thank you so much for having us. We're sort of kicking the trend here of maternal health, but we will remind you that strokes happen in pregnant patients as well. So hopefully that will perk everyone's ears up. And our presentation is more about an idea of what we're hoping to achieve within the stroke network by identifying gaps and opportunities for how we can reach out to our rural health members. So I'm just trying to advance our slides. There we are, and here's our team. So we're sort of a curious group of neural-minded people. Myself, as Pam Rishka, is a clinical nurse specialist for the Stroke Network.
My name's Marie McClelland. I'm a registered nurse with 25 years experience in emergency and critical care nursing, and 13 years specifically doing stroke research. Currently, I'm employed as a clinical research coordinator at Interior Health.
And we also have two team members, Dr. Alex Takash and Corey Bendall, who are leading the way in the expedition of trying to expand research into the rural communities. And we also find that our team is actually growing quite a lot as well. So we're starting to get a critical mass of a lot of exciting partners in this work.
So currently, clinical stroke research trials are being conducted only at Kelowna General Hospital. There are clinical research departments at both Kelowna General Hospital and Royal Inland Hospital in Kamloops. We're exploring what is feasible with IH resources and how to build a process for inclusion of all IH stroke admitting facilities. So the previous slide was showing just Kelowna and Kamloops. This one is sort of what we would like to see in the future. So this summer of 2020, we applied for and received a 2-year grant from the KGH Foundation to support a research coordinator position for the IH Stroke Network. One of our priorities is to improve participation in research in communities that would otherwise not have access to trials, and as a result, improve stroke care across the region. And you can see we have a few more stars on this map that show a few places that we would really like to explore the possibility of taking stroke research to.
And I think those reflect really the CT-enabled sites. So we're hoping that all those smaller communities and rural community members would be able to feed into those CT-enabled sites so that we can get a larger encatchment of all the patients that are reflective in our interior health. But when we think about why we do this, we really sat down and thought, you know, the principle behind all of this is that every person matters. And that's the interior health tagline that spoke to us most. And we felt like no matter where you are geographically in the province, you should have the same equitability to care, as well as the same equitability to participation in research. And we felt like that should be accessible and made possible. And by doing so, we would raise the participation of our healthcare providers, the microscope on what we do to provide care, and overall improve the excellence of what we do with stroke care in all of our communities. And so when we sort of broach this idea with our partners and hear from our community members, some things we hear for concerns or possible barriers is my site is too small, our stroke numbers are too low, we don't have research experience, and we don't have the resources. So to get over this, we were trying to be creative to say, well, how do we actually be accessible and inclusive and equitable, knowing that we're going to have to, you know, provide structure and mentorship to sites that need help to be able to achieve this. And so the hub and spoke model is our primary approach, where we would say that we've got exceptional team members of researchers and data collection and all of these things that maybe could be cohorted into one area where it feeds the smaller communities feed in our patient you know, data and referrals, and that we support them with the research structure from experienced sites to less experienced sites. So we sort of see ourselves as a really branched team that way. And that's the hub and spoke model that we're going to take. And then per site, we're trying to figure out what is absolutely necessary on the ground and keep it bare minimum so that it's feasible for everyone to join in. And we'll do an assessment per site to figure out what that is.
So this slide sort of shows a lot of the questions that we are faced with. And we think there are some what we call low-hanging fruit and some example study designs that might apply. One of them is the ACT study, which is currently enrolling across Canada. This study is comparing IV alteplase to tenecteplase for acute stroke within 4.5 hours of symptom onset. To date, we have enrolled 7 patients here at KGH, and this study will eventually enroll 1,600 participants and is projected to finish in December of 2021. The other one is the Optimized Stroke Registry. This is for acute stroke. It's a Canada-wide registry for patients who receive thrombolysis or endovascular therapy, where we go in and actually physically remove the clot from the blocked artery in the brain. There have been 60 patients from KGH entered into this database since September of 2019, and enrollment is ongoing. Other possibilities also include retrospective study designs and studies that use already collected data. Now, this picture shows Corey Bendel and 2 BC ambulance people outside of the Caribou Memorial Hospital. And this was just prior to
1 minute left.
Thank you. This was taken just prior to them becoming a TPA-enabled site. So Frontier study is one that we're doing here in Kelowna, and we have seen that by running clinical research in a community actually raises the care provided. This has been supported by academic publications pertaining to this subject. This has been illustrated here in Kelowna with Frontier, and the education the study provided to our paramedics. What we observed is that they developed more accurate identification of stroke and improved handover reporting when they arrived in the emergency department. And our ED nurses took note of this and also improved their knowledge of stroke. And the net benefit is increased awareness of stroke and improved stroke care with first responders and in the ED.
So thanks for listening. We think it's great that you hold us accountable. This is our goal. Marie and I have it on our bulletin board that we're going to achieve this by 2022 or 2023. So we would love for you to sort of pose questions to us or maybe give us some advice or great lessons learned. Anything you'd like to talk about stroke related, what you would like answered in your community is also top of mind for us. So thanks for having us.
Thanks, Pamela and Marie. That was great. Love your slides. So questions? or questions that you think are important for research in rural communities around stroke?
We have lots, so that's okay.
You have lots, so you don't need
We have so
more.
many questions about stroke-related questions ourselves. But yes, if you have any, please send us an email afterwards. We'd love to hear about it.
Yeah. Just one question from my perspective. Are you including patient partners as well in your research?
Absolutely. Mm-hmm. Yeah, thanks for that. It's such a key thing. And I was reminded when April was talking how important their perspective is, but we have a patient member and his wife specifically on our group right now, and as well an Aboriginal partner for our work as well. So the team, like we showed at the start, was just, that was who developed the initial budding idea, and it's now just sort of expanding at an expedited rate for who we participate with.
Wonderful. That sounds great. Okay, thank you. If there's any comments or questions, please just connect with Pamela and Marie directly. And we have Jude back up.
Great. Thank you. Thanks, Nellie. Yeah, so for this presentation, I'm going to be talking about out-of-pocket costs for patient travel in British Columbia. And I'm really stoked about this project. What we found in our fieldwork over the past decade, going to rural communities, regardless of the content area that we were talking about, if it was maternity care or surgical services, the issue of rural transport came up over and over again, specifically about the difficulty that citizen patients have about leaving their community to go access specialist care or diagnostics or whatever they need outside of their community. And if it's an urgent care visit and BC Ambulance gets them to where they need to go, the challenge of getting back home. So we heard that heaps and loads of how stressful and expensive it is, and we would relay that to our decision-making partners all the time. And we would get questions of, well, how much does it cost? And we didn't exactly know. So that's kind of the lead in. And I will, again, I'm still on Salt Spring, the beautiful home of the Coast Salish Saskatchewan Nation. A little bit soggy today, but still very gorgeous to be coming from here. So the funding for this study was actually through the Health Economic System Modeling Cluster through the BC Support Unit. And we received that last year. And the objectives were to engage with citizen patients, to really assess in depth, to dig really down into the costs of traveling to access healthcare. And again, for non-urgent travel to regional referral communities for diagnosis or diagnostic procedures or consults with specialists. And again, the return trip back after patients had been hospitalized. So we kind of compiled it all into a report, and I'm going to be talking a little bit about the findings. But first I want to say that we really engaged patient partners from across the province, from 4 different geographies in all of the work. They provided really good input into the kind of questions we should ask, some of the questions that were not received super well when we asked them in the way we did, and most importantly, helped us understand the findings when we started analyzing the data, the implications of the findings from a lived experience perspective. So just super quickly, we had great response, 379 completed surveys from all across the province, and you can see the map. Of course, the size of the dot indicates the volume of response, but we had pretty much all of the province represented, all the health authorities represented, with the most responses from Interior Health. So in summary, the take-home thing is the average respondent suggest or reported that they had spent $2,234 out of pocket to access healthcare. Now, this could be for one visit, but more likely it could be for several visits for the same condition over the time period. So we asked for people to report on getting access to healthcare for one condition. So that was the average amount spent. The average transportation costs were $777, and that I'll go into a bit more depth in a minute, but that was either plane, often for gas, ferries, etc., to get to where they needed to go. And average accommodation was $674. Again, out-of-pocket cost per citizen patient. Almost 60% of respondents said that without a doubt, traveling to access healthcare negatively affected their health on top of the existing condition that they were grappling with. Only 14% of folks responded that they would receive financial assistance from any organization for out-of-pocket costs, most primarily through the TAPS program, the Travel Assistance Program through the Government of BC, Ministry of Health, and also through Uninsured Health Benefits, FNHA's program to support Indigenous, status Indigenous residents. And almost 80% of participants suggested that they had difficulty for paying to access costs outside of their community. So pretty stark hearing back from community members. So super quickly, when we talked about the average travel costs, the average distance traveled was almost 2,000 kilometers. And again, this could be for one trip if you're coming from the far north, or it could be for multiple trips back and forth. Obviously, the further you travel, the more you spend. The very, very high number of kilometers on the right represents people who had multiple trips for chronic care management outside of their community. In terms of accommodation costs, the interesting thing to note here is almost 60% of respondents paid for accommodation, but the almost 50% of the respondents who paid for accommodation, or 50% of the respondents, stayed in hotels on average of 5 nights at $146 a night. So you can see clearly how quickly that adds up. Northern Health and Vancouver Coastal had the highest rates of travel cost. And I will remind people that Vancouver Coastal Health includes the Bellas, so Bella Coola and Bella Bella. And it is very expensive by either long boat or by plane to fly from Bella Bella and Bella Coola. So that's where most of the costs came from. And also Northern because of the distance needed to travel. Now, of course, we want to make sure that patients and citizens have the social support they need when they're going to access care. And 31% of the respondents said that they had separate co-traveler costs for people who are supporting them, bringing them to care, or importantly, if they were in an acute care situation, bringing them home. And it was mostly, as you can see, around cost for either airplane tickets or gas, of course, bus tickets. Almost around 14% of the respondents had travel assistance through, again, as I said, through TAPS or FNHA, and only 2% of the respondents reported accommodation cost support. This is because TAPS doesn't actually cover accommodation costs. TAPS only covers travel, mostly ferry costs, but to get to your specialist support. So you're still left with accommodation costs, which, as we can anticipate, could be very expensive. 93 respondents reported specifically lost wages, and this is where it becomes very interesting. If you're, as a patient or as your support, has to be away from work and you don't have any coverage of that, that becomes incredibly significant. And we heard many stories about how difficult it was for either partners or other family members or people looking after their elderly parents to be away from work, and the financial impact of that. What we're hoping to do moving forward is, of course, reiterating the importance of comprehensive costing. So we need to look at all the costs involved when we're planning where to put services, not just the health system costs and the structural capital costs. But most importantly, I think right now we need a broader discussion involving provincial, regional, municipal stakeholders about where this responsibility lies. And we're in conversation with the Ministry of Health and the health authorities to figure out how we can bring people together right now, virtually, of course, but to acknowledge what everybody feels is the need for a social safety net. We need to be able to support people who might have trouble affording to get to care if it's not available locally. But where it actually lies, the responsibility lies, is a little bit up for grabs right now. We need to have this discussion, and it's probably going to end up being a combination regional and provincial sources, but we're just engaging on how to create that table to discuss. And that's it. And Nellie, I think I made it in under the wire.
You have a couple of minutes for questions. And there is a question here. How do you think COVID will or has impacted telehealth and out-of-pocket costs?
Yeah, so we've heard a lot about the appreciation of the, I guess, the rapid adoption of what rural community citizens have been saying for decades, which is why can't they do more? For example, pre-surgical care, pre-surgical screening, and post-surgical follow-up by telehealth. We get that all the time. The notion of driving, for example, from the East Kootenays over to Cranbrook and spending 6 hours in the car for a 10-minute visit doesn't make sense. So because of the need for virtual care because of COVID, even locally in the community, has really raised the bar of expectation for, okay, we can do this. We've got the systems in place. We need to be able to do it for specialist consult. Now, of course, there's going to be incidences where you cannot. You need to go to the regional referral center. But again, transport out should be our last resort. We really should be thinking about, first of all, having specialists come to rural communities as itinerant or outreach specialists to do clinics. Second of all, virtual care. And then if all else fails, then transport out of the community.
Okay. There's one additional question, which maybe you can answer in 20 seconds here. Patients included. Accreditation, in other words, from the beginning or just a task force of patients?
You mean for the provincial table?
I think so.
Yeah, no, definitely from the ground up. This has to involve patients setting the priority. And I feel so strongly, and I'm sorry if this goes over 20 seconds, but that we can't be deciding what the topic is and then saying, oh yeah, we need some patient voices. Not that those voices aren't important to bring at the table. We need to reverse that a little bit, turn it around and have patients articulate what the priorities are. So in this instance, definitely from the ground up, deciding what the discussion topic should be.
Good. Thanks, Jude. And we have Sila. I'm hoping I'm pronouncing that correctly. Up next.
Thanks, Dr. Elliott. Yes. I will, can I share my screen?
Yeah, yes, you can.
Thank you.
Go ahead.
My name is Sila Rogan, and today I'll be presenting with Diane Kim on enhancing rural health services and community resiliency through research through the Rural Health Services Research Network of British Columbia.
Sorry, I had a quick technical difficulty there. Can everyone hear me? Okay. So before we start, we just want to briefly acknowledge that I am joining from Port Moody, which is the traditional, ancestral, and unceded territories of the Coquitlam, Musqueam, Squamish, Stolo, and Tsleil-Waututh nations.
And today I'll be calling in from the traditional, unceded, and ancestral territories of the Musqueam Nation, which you may know as the UBC Point Grey campus.
So in today's workshop, we would like to introduce our network and some of our major works, and also highlight our upcoming virtual symposium on climate change and adapting rural health services. At RCSR our vision is to support BC's rural health researchers through connecting them with each other, but also to other useful resources. And we ultimately strive to strengthen three core components of rural health research, which is capacity, collaboration, and communication, to create better health services for our rural communities. Our team is led by Dr. Stefan Grzybowski. We also have 4 other regular team members. We also have 7 advisory committee members who bring their expertise and insights from across the province. And Dr. Nellie Golke is one of our members as well.
Thanks, Diane. So we're able to fulfill our mandate to create supportive infrastructure for improving rural health services through research through various activities. Broadly speaking, these involve funding opportunities for rural health researchers, as well as knowledge translation activities. Moving forward with some of our funding opportunities for network members, we do have our team building awards, which provide researchers with up to $2,500 to develop a research team that is investigating a research topic that's relevant to rural health services. Within the context of COVID-19, these funds may be used for helping rural health research teams transition to an online virtual environment. You may recognize some of our previous Team Building Award recipients down below on this slide. We also provide funding for UBC medical students to pursue research interests in the areas of rural health. The Flexible Enhanced Learning, or FLEX program, is an undergraduate medical course offered by UBC for students to pursue individual learning interests in depth. And we provide $500 travel bursaries to first, second, and fourth year medical students. Previous projects are also listed below. Finally, we provide travel bursaries to promote knowledge translation and sharing rural health research at international and national conferences. This funding may be used to subsidize travel costs for rural health researchers. However, it has unfortunately been suspended due to COVID-19, though we're hoping to resume this program as soon as it is safe to travel. Moving forward with some of our knowledge translation activities, the network releases a newsletter several times a year. It's basically a resource for sharing information relevant to rural health, as well as important resources that may be of use to rural health researchers. In our latest edition, you can find information such as new publications on rural health projects, as well as spotlighting some of the amazing work that's being done by rural health researchers. We also have annual symposiums that bring together key stakeholders to have important discussions and honest conversations about issues that are relevant to rural health. We'll be having one this year that is focused on climate change and its impacts on rural communities. But our past symposiums include emergency services, mental health and substance use, as well as maternity care. Additionally, we publish several reports and articles on rural health services, which draw attention to the health needs of communities. If you're interested in reading some of these publications, they're available on our website, as well as UBC's Circle repository. We also developed a virtual storyboard, which allows rural communities to tell their stories about how climate change has impacted the health of their communities. Our virtual storyboard is centered on amplifying community voice, and additionally to make information on climate change and its impacts on rural health more accessible to the general public. Finally, we have our Catchment and Gis Platform, which is a tool that can be used by researchers to understand geographic patient flow patterns in rural British Columbia. To our right, there's an example of what one of these maps look like. And essentially, we've developed maps for 42 communities that show 1-hour drive times to rural hospitals. If you're interested in some of these activities, or if you'd like to become a network member, you can easily do that today by filling out this form. We'd love to have you as a part of our network, and I will additionally be putting this form in the chat.
Sorry. Thank you, Sila. As she just mentioned, we are working on a virtual symposium, and this has been our major work for the past year. And in this event, we're inviting all partners of the Pentagram Partnership, including community members, health administrators, healthcare providers, and policymakers. The goal of our symposium is to create a safe space to discuss the health effects of climate change and how to move forward in planning climate resilient communities and rural healthcare systems. This event would take place in 2 days, divided into morning and afternoon sessions, and each session would be uniquely focusing on a specific topic, which is outlined on the slides. Through our symposium, we hope to foster new collaborative partnerships, identify research questions, and potentially develop policy initiatives to really move forward our discussion into practical outcomes. And if you guys are interested and would like to learn more about our event, you can follow the QR code on the right, which will take you to our symposium event page. And also to lay out our current understandings of climate change in rural British Columbia, we have put together a couple of resources that our participants can look over prior to the event. And the first one is our background document, which is consisted of 4 chapters. The first 2 are already published and available in UBC Circle repository, and the next 2 would be coming very shortly. And similar to our event page, if you would like to actually read over our document, you can follow the QR code on the right. Lastly, as Hila has mentioned, we've been working on a virtual storyboard, which would act as a visual summary of our background document with additional integration of community stories and also some interactive activities to engage with our audiences prior to our event. And once again, there's a QR code unique to our virtual storyboard if you guys are interested and would like to check it out.
You're almost out of time.
Yep.
And great.
So we would like to extend our invite to everyone in this chat or in this Zoom room to join with us in this important discussion. And if you have any other questions, feel free to reach out to us at this email. Thank you.
Thank you, Sila and Diane. Great presentation, and yes, a great plug for both the symposium and also the network itself. One question I believe was answered. Somebody was wondering where to access the virtual storyboards. So you did provide the QR code, but they could also contact, I'm assuming, look on your website or contact the email address, right?
Yes, for sure.
Yeah. Okay. Any others? Oh, there is another question. Sorry if I missed it, but did you say whether a recording? Yes, Joanne, the sessions are all recorded, so there will be a recording posted of all of the sessions. I think we'll move on. Thank you both.
Thank you.
And we will move on to our last presentation. And just let me get, I'm not going to pronounce the name correctly here, but Gadis Doguio, Daniel and Martin.
Okay, so good morning, everyone. My name is Gadis Doguio, and I am the graduate research trainee for the Making It Work study. I'm Ganyagehaga from Kahnawake, which is back east in Quebec, and I'm currently living on the unceded territories of the Lekwungen and Wasanic peoples. I'll hand it over to Daniel.
Hello, my name is Daniel Sands. I'm a proudly gay and two-spirit Cree Métis European descendant of a residential school survivor from Treaty 6 territory. I'm also on the unceded territory of Lekwungen speaking peoples of the Esquimalt, Songhees, and Wasanic nations, also known as Victoria.
And my name is Martin Morberg. I'm Northern Shoshone and Tlingit, and I am a guest living on the Coast Salish territory here in Vancouver of the Musqueam, Squamish, and Tsleil-Waututh nations.
So today we're here to talk about our community-based research study that is called Making It Work. It is a study that is co-led by the Pacific AIDS Network and the AHA Center. It's a community-based research study looking to highlight services for people living with HIV, hepatitis C, and or challenges with mental health or substance use work, best for people who are accessing them. This project has a particular focus on services that are provided through an Indigenous worldview of health and that have a commitment to cultural safety for their clients. Making It Work was born from discussions between community service providers and people with lived and living experiences who wanted to showcase the important and diverse services being provided in the community. Making It Work has a long and rich history of collecting different team members and their experience into what it has evolved into today. As you can see here on the screen, we have different study locations for the Making It Work project. It is a study that is ongoing and is happening throughout BC. So these are the community case study sites. So the first one at the bottom left is PHS, which is located in both Victoria and Vancouver. There is Positive Living North, which is located in Prince George, as well as Smithers, and then Central Interior Native Health Society, which is located in Prince George. Secondly, we wanted to talk a little bit about the approach that the study uses. So we use the two-eyed seeing framework in order to guide our study and our work as a team in order to prepare for the data collection phase of the community-based research. So two-eyed seeing foregrounds Indigenous knowledge with the understanding that to improve and advance Indigenous well-being, research needs to honor diverse and evolving Indigenous approaches to health and well-being, while also recognizing the value of Western scientific approaches to health. In this project, Indigenous ways of knowing and leadership from Indigenous team members guide our work through a Western approach, which is realist evaluation. Our study team has been learning where these approaches complement each other, as well as how to make sure our values and commitment to community-based research and decolonizing research methods are not compromised in an Indigenous context. I'll pass it over to Daniel and Martin.
So yeah, we do have peer research associates located in Vancouver, Victoria, Smithers, and Prince George. For me, my position as peer research associate has been very meaningful and significant to me personally. I'm not just a person with lived experience in an advisory position receiving an honorarium. I'm a paid staff member. And this is a very important distinction. I'm not just someone who ticks a box or is tokenized. I'm a paid staff member who brings my expertise in my experiences with me in the ongoing development and project design of the Making It Work study from the very first day that I joined. And I also wanted to say that it's extremely empowering to me that all of my challenges with mental wellness, my experiences of homophobia, homelessness, poverty, structural marginalization, my past substance use and my current sobriety, my HIV positive status, my accessibility challenges while using a wheelchair, like all of those challenges and experiences, they're not just valued in my work with this study, but they're necessary to help those without these experiences gain some understanding about those perspectives. And pass it on to Martin.
Hi. So yeah, I just wanted to touch a little on the importance of involving peers with lived experience. Just making sure that when you're working on Indigenous projects, that the knowledge that you're accessing is authentic Indigenous knowledge, and ways of sharing that knowledge and ways of knowing and doing. I know that for a lot of the services that I accessed in my own experiences, I was looking for my own identity. And so it's really important that I was able to identify culturally, also to identify with other people in recovery from addictions, people on a healing path, and other people with experience with HIV. I think the Indigenous way of knowing and doing for me has always been around relationship building. So I think it's really important to involve peers in that aspect, to build community, to build trust, to have peers establish relationships, and then are able to support and encourage community members in accessing these services. So I think another point would be that peers are involved in the decision-making processes. And I've seen this, and I've sat on a lot of committees and boards, and it's like people are making these large decisions on how to tailor services to the community, and the community isn't even sitting at the table. And so it's really important that people with lived experiences are involved in the decision.
That your time is running out.
Okay. All right. And then just another part too is like investing in peers. And when I say that, I don't just mean like working reception or volunteer experience. I'm talking about the training, the advancement, leadership opportunities, program facilitators and coordinators, board leaders, and really empowering your peers to extend their resources and knowledge into community. So I just wanted to add one last point is that this study values their peers, their Indigenous peers, and it's a really good example of how peers can be involved to offer recommendation and contribute to studies like this. Yeah, I'll leave it at that. Thanks.
Thanks, Martin. And Daniel, we just wanted to put up a slide here really quickly just to guide you to our website, which is the link at the top. And I can also put that into the chat box. And then my email is here as well if there's any further questions. And what you can find on the website is a project brief, history of the logo, the two-wide seeing approach that I touched on briefly earlier, and realist evaluation, and team biographies, which are going to be forthcoming. Thank you.
Wonderful, thank you. Great project. We have time for one quick question. Okay, there doesn't seem to be any questions. I'd encourage you to go to the website and also to contact directly so that you can find if you have additional questions or want some further information. So thank you all. And I just at this point in time, we are close to finishing up this session. And would like to thank all the presenters for their wonderful presentations and also wonderful questions that were raised as well. So some really important work going on in rural health research, and just a pleasure to be part of hearing about that and learning and moving rural health research forward. So I just want a quick reminder to everyone to log in for session 2 at 11 a.m. I have copied the link into the chat box and we'll get that out. And that session again will be very different than this one. And we'll have an opportunity to have that discussion with Indigenous elders, with patient partners and other community members. So you have 4 minutes to have a stretch break. So look forward to seeing everybody in the next session.